Okay, that's recording. Yeah? Right. I haven't bought any sweets, so any ideas you had of getting sweets, you must forget about that now, unfortunately. So, we're doing vascular disease. I'm sure you're probably expecting that. My name's Amit, and I've got Bori here as well. Right. These aren't our feet, so don't worry about that. Okay. I was expecting a bit more. I've just found this thing where you can like draw on it. So that might make it a bit more interesting. Okay, so this is what we're going to cover today. We're going to keep it quite simple. I'm sure you guys want to get home and study or relax after today. We're going to go through vascular history, examination, ABPI, AAA counselling, which is an OSCE station, another OSCE station, which is the history. Any questions and any feedback? So we're just going to ask some questions first. What's the difference? What's the differential for painless leg that's a medical emergency? Say again?
Acute ischemic limb.
Acute ischemic limb.
Yeah, that is actually.
Okay.
Compartment syndrome.
Compartment syndrome. Is it painless? Okay, anything else? Okay, next question. Between which bones is the posterior temporal pulse palpated? Anyone know?
Medial hiatus.
Yeah, and?
Another one.
Okay, we'll come back to you. What's the tap test for?
Is it vacuum vein where you like tap
Good,
it?
yep. What do you give for VTE with patients with renal failure?
Half a dose.
Say again?
Half a dose.
I don't even know what that is.
Not alright.
Okay, what is the treatment dose for a PE?
Whatever the wall chart says it is.
It's not on the board chart actually,
No, you have to know.
and it's not even on the instrument. Okay, we'll come back to that, okay? So I'm not going to patronise you with vascular history. It's all the things you'd normally do. Just a couple of things to point out, which is the majority of patients with vascular history have underlying comorbidities related to cardiovascular risk factors as well. So just ask about that if you are doing a vascular history. Okay, so we'll look at some presenting complaints. What are presenting complaints for a vascular history that could come up in your OSCE?
Claudication.
Claudication, good. Anything else? I mentioned one already. Varicose veins, yeah.
PE.
PE, not really vascular.
I mean DVT.
DVT, okay, yeah. Two different things. I'm just joking. Ulcer, good. Anything else? I mentioned one in the second slide. AAA. That was in the. I'll mention one in the third slide. Painless limb. Okay. So there are things that are likely to come up. So this patient come in with this, take a full history. The two that we're going to concentrate on today are intermittent claudication and the painless limb as well. Okay. So what is the definition of intermittent claudication?
Pain in the calf
Okay.
that's intermittent and it stops while resting without necessarily sitting down.
Good, okay. That's good. It doesn't have to be in the calf though, does it? It can be anywhere. It can be in your hamstring, it can be your buttocks, it can be anywhere. So, pain that's brought on by exercise and is released by rest. When you take a history, you need to ask about exercise tolerance. So what was it a year ago? What was it 6 months ago? What is it now? How far can you walk? On a flat ground upstairs. Your normal pain history you're obviously going to ask as well. And any other abnormal sensations you would get with vascular problems. Paresthesia, cold limb, we'll go through those in a minute. Okay, so with intermittent claudication, the level of vascular stenosis always lies one level above the most proximal symptomatic muscle group. That just sounds, well, it's fairly straightforward. It just means that the symptoms you get are below the level of where the stenosis is. So if it's aortoiliac, then you get in the gluteal primary, iliofemoral you get a bit further down, and obviously fempop you get in the gastrocnemius soleus inferior. Okay, painless limb. I know I'm flying through this quite quick. You need to ask about time course. Ask about pain as well, because I know it's painless, but you do get some pain. What are the 6 P's?
Parachute cold.
Great. Okay, so you got all of them anyway. So they're the things you need to ask about as well. I'm hoping this presentation is going to be online for you guys to have a look at. The other things you want to ask about with a painless limb. So what is the cause of it? Where's the source of the embolism? Because that's what causes painless limb in vascular disease. We're not talking about all the other things we mentioned. So is there AF, is there valvular disease, and aneurysms and previous disease as well? You need to look into that. So they're questions you'd want to ask if a patient has a painless limb. Risk factors for thrombosis, I'm sure you know them. So they're related to all the things you get in a DVT as well. So trauma, immobility, dehydration, cancer, all those things. And obviously ask about the cardiovascular risk factors as well in peripheral vascular disease history. Is it important?
Yes.
Why? Because it's a medical emergency. So if you do get, obviously, a painless limb due to a clot that's fallen off from an aortic aneurysm, then there's a likely chance that you can get loss of that limb if it's not treated quite quickly. So the causes are emboli, trauma, and we said actually compression. I forgot about that. And so the other causes of painless limb which can be quite serious that you need to take into account are cord requiner. So you get pretty much the same symptoms. The other things you have to just ask for is back pain and paresthesia. And if you have that, then you've got cord requiner, which is also quite serious and needs treating quite quickly.
Right, okay guys, I'm just going to do the vascular exam. I'm not going to get anybody to come down and do it because if you do get it in an OSCE, it will be a patient with signs. So I hope none of us have signs of vascular disease. So I'm just going to briefly go through it, and if you have any questions, just stop me and ask. Right, so just as any examination, you need to make sure patient's consent is obtained. You introduce yourself, wash your hands, etc. Sorry, why is this like not coming? The animation's not coming.
I have no idea.
Anyway, so all the answers are on there. What you're looking for is just general observation. How does the patient look? Is he comfortable at rest, etc. So you're looking at, this is mainly for the lower limbs. So any scars, what kind of scars are you looking for? So varicose vein surgery scars, yeah? Bypass scars, do you know what they look like? So they're quite obvious. They will be running through mostly the medial aspect of the leg. They're quite obvious. So mainly scars, but if you don't know what it is, as long as you describe that there is a scar there and where it is, you will get the marks for it. So muscle wasting, color of the legs, is there any pallor, is there any cyanosis, if there's any hair loss or tissue loss. Now, a lot of people forget about if there's missing toes. That's really important, and when people look at it, they think it's quite obvious, why would I mention it? But actually, you do get marks for it. So often in diabetic feet, etc., you will get missing toes. So ulcers, what's the difference between arterial and venous ulcers? Someone from the front row.
Arterial are punched out, and venous are...
Yeah, good. Anything else? Someone from the third row? Any other difference between venous and arterial ulcers? So the sites, where they are, where do arterial ulcers occur? What kind of sites? Anyone? Pressure areas, that's right. Yeah. Okay. So also you need to look for varicose veins, varicose eczema. This is a picture of varicose eczema. And don't forget to look in between the toes and lift the foot up and look at the heel as well, because often ulcers, diabetic ulcers are there. Alright, so palpation. So you're palpating for the skin temperature, and you're doing that with the back of your hands and compare each leg. So you're palpating for tenderness, capillary refill, the pulses. So these are the main pulses that you would do in a vascular examination. And even if it's a lower limb examination, you'd also offer to take the radial pulse, because patient may have AF, and that can be indicative of embolic source for the lower limbs as well. And you'd also palpate the abdominal aorta. They're not likely to give you someone with a triple A. Although we did have a case in an OSCE where a patient had a AAA, and the student pressed so hard that the AAA actually burst and the patient had to go to theatre. So that student actually failed the exam. So just don't press too hard. Right. So the post is in the lower limb. You need to know the arterial tree in the lower limb. So if we start off from the top, your abdominal aorta, you go down and it's the common femoral artery which you're actually feeling for. And that's exactly midway between your ACEs and your pubic symphysis, midway through that. It's just at the level of the midinguinal point. The popliteal artery, it's quite difficult to feel. And if you can actually feel it, that's in a clinical situation, not in an OSCE again, it can be indicative of a popliteal aneurysm. So usually, popliteal artery is very difficult to feel. The posterior tibial artery is between your medial malleolus and your calcaneus. So that's one of the answers to the questions earlier on. And the best way to find it is if you find the medial malleolus, just go posterior to it and you'll be able to feel it there. So that's your main landmark. And then it's your dorsalis pedis, which is a continuation of your anterior tibial artery, which runs on the lateral aspect of the leg. So you can feel it on the dorsum of the foot, anywhere from sort of between your first and your second toe down. And some patients, there's about 2 to 3% of the population which do not have a dorsalis pedis pulse. So, yeah, if you can't feel it, it might be that very unlikely. Okay, so auscultation is not a major part of the vascular examination, but you would probably like to mention it, and that's what you're feeling, that's what you're listening for, any bruise. Right, okay, so any special test, this is probably the most sort of famous test you would do in a vascular examination, Berger's test. Have you all heard of it?
Yes.
Yeah? Right, okay. So the way you do it, I don't know if I can demonstrate this on somebody. I haven't really got a couch.
Anyone volunteer?
Anyone volunteer?
Yes. No, Toby.
Toby, why don't you come down? That's your name I heard.
There might be a couch outside.
Right, thank you. Round of applause. Okay, so do you want to just...
Where do you want me to go?
Just up here. Can anyone see? Can everyone see?
I think
Right.
you
You
should
sit
buy
on
one for
the side of the lecture.
Anyway, we'll just do it here. Right, do you want to swing your legs around? I'll just go through it. Yeah, just lay down. Right, okay. So Berger's test, what you do is, so you lift both legs up. Right. So you lift both legs up, right?
Yep.
Just lift your legs up, right. Okay. To about sort of 45 degrees, roughly. And then you're looking for the color change in the legs. In normal healthy person, you wouldn't really expect the legs to go pale. You should actually be able to lift your legs up to 90 degrees without any color change. If someone's got peripheral arterial disease, and if that's very severe, the angle that you lift the legs up, that will indicate of the severity of the disease. So some patients, you may only lift it up to sort of, I don't know, 20 degrees, and the leg will go pale.
Do you lift both up at the same time?
You can do each. You can do each. If you know that one leg is affected, then you do one at a time. Yeah. Right. And then you get the patient to sort of sit up. Okay, do you want to sit up? And you swing the legs around. Sorry, you can't really see this. And what you're looking for is the color change. Now, because of gravity, the blood flow is going downwards. So that's sort of helping the leg. But if you have an ischemic leg, right, the color change will go from white, which is the pale indicative of ischemia. It will become blue because there's the oxygenated blood going through that ischemic tissue. It's not being able to pick up the oxygen, and that's why the legs go blue. And then after that, they will go red due to reactive hyperemia, which is sort of the post-hypoxic vasodilation of the vessels. Right, so the color change is white, blue, red. Do you understand why? Why that color change occurs? Yeah? Okay, right, thank you. Okay. And then there's other various special tests which you're very unlikely to have to do, but you just need to know that they exist basically, and they're mainly for varicose veins. I've never heard of an OSCE on varicose veins, so they're unlikely to come up. Right, now this is the ABPI. It's very self-explanatory. It's basically the ankle pressure divided by the brachial pressure. So the way you do it, right, might just show you on here. So this is your, it's basically the same as a blood pressure cuff. Can everyone see here? Yeah. Right. Well, this is not ideal. I'm not actually going to do it, but I'll just show you some of the equipment. I'm sure you're familiar with it already. Yeah. So what you do is you take the systolic pressure from both brachial arteries as if you're going to take the blood pressure, and then you take the highest reading of that. Okay. So you don't really need a Doppler for that. You can just really take the blood pressure. Right. And then you have to do it for each leg. So then say you take the right leg. So you get a bit of jelly, put it on, and then you switch this on. You've all seen it yet from here. And then you find the dorsalis pedis artery and the posterior tibial artery. So you inflate the cuff until it disappears, and then after it comes back, that's the reading that you want to get. Does that make sense? It's probably easier to demonstrate it. But when it actually comes back, it's just like the blood pressure. That's the reading you need to take. Okay? So you do that for each leg, and you take the highest from dorsalis pedis and posterior tibial, and then you divide that reading by the highest from both brachials. And you do the same for the left leg. Okay? So it's very self-explanatory really, but it's just a matter of if you do get it in an OSCE, you know what the equipment looks like, you know that you have to be nice to the patient, don't forget to like give them tissue and rub off all the jelly, etc. Those kind of things pick up marks. Okay, so there's various sort of cut-off points in books, and everybody sort of remembers different things. But the main ones you need to know is what's normal, which is 0.1 to 0.1. 0.9 to 1, that's normal. Less than 0.7 is sort of indicative of some sort of PVD or PAD. And then less than 0.3, we're going into sort of gangrene and critical ischemia. Now, I did get asked questions like, what if the ABPI is more than 1? Now, that usually happens in patients who have diabetes and their vessels are calcified. So it's just something that you should roughly remember those cut-off points, but they do vary in various books. Okay, so that's just a picture of what you would do in sort of in clinic, or if you were on the ward, just to make it easier and write your readings down. And we usually do this post and pre-surgery just to see how much the leg has been perfused after a patient's had vascular surgery. And this is again how it's done, just to sort of remind you. So the Doppler sounds, you don't really need to know about them at all. All you need to know is what's normal, and that's the triphasic ones. Even the vascular registrars, they can't exactly tell which sound is which. I've seen it myself, they get muddled up. So just remember, the normal is triphasic, okay? And again, the diabetic patient with the calcified vessels, something that you need to keep in mind. Okay, so at the end of the examination, don't wait for the examiner to ask you lots of questions. Just initiate it yourself and say, so summarize the patient like you would for any examination, and then you say, to complete my examination, I would like to measure the ABPI, perform Dopplers, and I would also like to perform a full neurological and cardiovascular examination. Thank the patient, wash your hands, etc. You know all that stuff already. Okay, is that all right? Yeah.
Okay, we move on to counselling station. This came up in 2005 and then again in 2009, and it wasn't the last 2 years, so chances are it could come up. So Mr. PF is a 66-year-old man referred to vascular outpatients department after discovering 4 centimetre AAA on ultrasound scan for kidney stones. You're the F2 in the vascular clinic. Please explain the diagnosis to a patient and counsel him on treatment options. So as you all know, AAA is a quite important diagnosis. Treatment's quite important as well. Prognosis is quite important. So what I want you to do is just between yourselves for a couple of minutes. Just so hang on, we'll come to that. So I'm not going to go through all this. So wash your hands, determine how much the patient knows, what they would like to know, what the concerns are, and always end with your scarf. So between you, just between yourselves, I just want you to think about what you tell the patient in terms of the anatomy and pathology of AAA, the potential complications of AAA, and the treatment options. And if you do that for a couple of minutes, then we'll go through them. So just do it in pairs. Guys, all right? Should we go through it? Okay, so I'll choose a few of you to go through a couple of things then, okay? So let's say for anatomy, so you have to remember you're speaking to a lay person, so it's a patient. So what are you going to say about anatomy? So let's say second row from the back, second row in. Is it Sam? You looking around?
Me?
Yeah.
Amy.
Amy, damn it, I knew it. Okay. Amy, what will you tell a patient about the anatomy of the aorta of a AAA?
The aorta is the main blood vessel that comes out of the heart.
Excellent, yeah.
And supplies most of the body with blood.
Okay, anything else about it? So you're going to tell me about a AAA, guys. Is there anything else you need to say about that?
About the AAA.
Yeah.
That because of the high pressure of the blood in some people, the aorta can kind of expand in size.
Okay.
And that can, as you can imagine, with a balloon, when it's not blown up, it's kind of soft and you can move it around, but as it gets blown up, it gets more tense, and the pressure builds up in it. And that can obviously lead to the complications of a AAA, which would be a rupture.
So why is that a bad thing then, doctor, if it ruptures?
And because it supplies all the blood to your body, obviously if it ruptures, you would lose some blood out of the main vessel,
okay.
And that would mean that your tissues wouldn't be getting the blood that they needed anymore.
Okay.
So that's something that we obviously don't want to happen.
Is that the thing that's quite scary, that the tissues don't get what they need anymore? Or the fact that you just bleed out?
Yeah, or you can bleed out.
Okay, excellent. That's great. I think you mentioned most things. So let's just go through the anatomy. So explain the aorta, as you said, is the largest blood vessel in the body, carries from the heart down to the legs. Usually 2.5 to 3 centimeters diameter, and if it's like an aneurysm, it stretches like a balloon. On average, AAAs tend to get larger by 10% a year, not too important to tell them. And it's 6 times more common in men, and affects 1 in 20 men over the age of 65. That's quite a lot, isn't it? Okay. So then it's nice to go through the pathology now and say the exact cause isn't really known. There are links with high blood pressure, family history, age, but there's no links directly known between why you get it. Increased risk in obese people and diabetics. You can be asymptomatic with AAA, like this patient was, so he went for an ultrasound scan, it's fine, or you can just have mild abdominal pain, back pain. And obviously that may be the differential on the outside of the OSCE wall saying, this patient's coming with lower back pain, and you need to rule AAA out, otherwise you probably won't pass that station. You can get small blood clots that break away from the AAA and then go down to your legs. Ultrasound is the easiest way to diagnose it, and men over 65 should be sent for screening. I don't think that actually happens. And you need to check the understanding of the patient and ask them if they have any questions. So let's go into complications then. So who wants to talk about complications? Chap in the grey jumper. What are the complications? So Amy mentioned them.
Me?
Yeah.
The rupture.
So when do they rupture?
When they're like over 8 centimeters or something like that?
Yeah, more likely to burst then, yeah. Okay, let's just go through that. So, as the size of the AAA increases, you're more likely to burst. Only 50% of those treated survive. I think that changes, depends on where you are, if you're in hospital, what kind of treatment you get. And obviously we don't just, the patient might ask, why don't we just operate on it now? Because obviously the risk of damage from a AAA, the risk of the surgery carries quite a high risk. At 5.5 centimeters, we know the risk of bursting outweighs the risk of surgery. Do you know what the risks are?
3 to 5%.
2 to 5% for
elective AAA repair.
Right, okay. And what's the risk of it bursting? So after 5.5 centimeters, the risk of a AAA bursting is 5% a year. So that's why after 5.5 centimeters they consider going into surgery, because the risk of surgery is less than the risk of it bursting. At this 4 centimeters, we'll monitor it every 6 months, and you can stop smoking, that kind of stuff, and obviously check the understanding. So what are the treatment options for AAA? There are lots, but let's go through the main 2.
Laparoscopic and open.
Yep, good.
So,
Did everyone hear that?
do you want me to say it louder?
Yes.
Laparoscopic and open. So
Yep.
laparoscopic laparoscopic, go through the femoral,
Yep.
and you put like a stent in. I think.
No, that's the other way.
Oh, sorry, I do. You go through the femoral, I'm not sure quite what you do, and then open is like an incision in the abdomen, and you put a stent in.
Correct. Okay. So the two main options. This is where they've obviously opened the abdomen and replaced it with a graft. As you said, it's probably it says 3 to 5% mortality. It's probably better now. 5-year survival is 50 to 80% because you can get a reaneurysm, you can get some sort of failure in that graft, and also subsequent deaths due to coexisting cardiac disease. And the other one that you mentioned was the AVAR. So it's when they put a tube in from the femoral and they expand this like a mesh to make it strong. I'm looking the wrong way. Okay. It's safe to do it, obviously, because you're not opening up the whole abdomen, but it does carry a 25% risk of failure, so it's a bit higher. So what are the things that you need to... let's go through the questions examined. So obviously you check the patient understands, ask for questions, and the leaflet and follow up. So what might indicate the need for an urgent repair? What signs have you seen in a patient? Say again? Hypertensive, yeah. What comes with hypotension? Cardiac, good. Okay, so say a patient comes in hypotensive tachycardic, their blood pressure is 90, but it's come down from 160. What are you going to do?
ABCD approach.
Great. That's always going to get you some marks. After that, what are you going to do? So,
Check the femoral pulse.
okay. So you're pretty sure it's AAA. They come in, you know it's AAA because they've had it in the past. They've come in and it looks like it's ruptured. Blood pressure. So you ask surgeons. He'll say they'll be there in 20 minutes. What are you going to do in the meantime?
Take them downstairs.
To them on. Say again. Theatre. What else? Fluids. Okay.
6 to 8 units.
Good. Now, why do you want to give fluids?
They're bleeding.
And how high do you want to get the blood pressure? Yeah. So I mean, at 90, you may not be too worried about giving too much fluids quickly, because it may just cause a bit more. Okay. So.